So, principles of prevention. Probably the most important lesson from this is look and think about how you handle isoniazid-resistant cases. That's the key to turning these ones into MDR. Now, I've given you the quote, nice guidance here. Graham doesn't really, I think, buy into this one, and for some good reasons. Anyway, the standard isoniazid resistance, if you look up your nice guidance, is rifampicin ethambutol in about 2 months, followed by 10 months with rifampicin ethambutol. You all know what the other alternative is if you really knew they were isoniazid resistant. Streptomycin in. Again, I'll show you the data, but if you're going to remember one regime, this is one to start with, and then I'll talk a little bit about the moxifloxacin regimes. So this is nice. This is one nice I'll tell you currently from the 2011 iteration. If you know they're isoniazid resistant before you start, which is, I would say, highly, highly unusual, you can give them streptomycin in place and curtail it down to 9 months. Okay, so what do the WHO tell us to do? WHO issued this in 2010. As I said to you, there is some evidence out there you should be using daily therapy, so just have a little think before you start. And extending rifampicin to 8 months in a blind retreatment regime seemed to have a better efficacy. And obviously, they recommend ethambutol as a protecting agent against rifampicin being mutated against. What do NICE tell us about drug resistance? Well, these always makes me chuckle because obviously everyone's books in London, by definition, should have radar up for this. Right, what do the Americans tell us to do? This is the CDC guidance from 2003. And Graham, I just commented on this on the left-hand case on the advisory side. So the Americans actually use all three for 6 months. So rifampicin, pyrazinamide, ethambutol. And if someone has extensive disease, use equivalent. Now, I'm showing this to you, by the way, so that you understand the problem with isoniazid resistance management is actually slightly controversial. Okay, I'd like you to think it was dead easy, but it is slightly controversial. But we have to arrive at some kind of standard, and I'm going to give you the kind of breadth of what there is right now. There are other regimes out there. You kind of look at the literature right now. So there's a Korean study, it's not the Korean study, this is the Jindani study, I think. So you have this is the basis by which the NICE guidance came out. So do RZES, then RE, for 6 months interval of 9 months. And you'll see here the relapse rates. So their shorter regime of 6 months actually did relatively well. The only difference was the relapse rates with patients who were resistant to both isoniazid and streptomycin. Anyway, I think that's basically where the body of evidence is for the current NICE guidance with non-fluoroquinolones. And then we look at people who have, let's say, high isoniazid resistance and low incidence, low isoniazid resistant patterns. And again, basically, there's not a huge difference. So it doesn't really particularly matter whether you get an HR on your result or you get a resistant. Okay? They sometimes will distinguish that. So these are moxifloxacin regimes, which we, again, a lot of us are using. You know about these two. So this is the London TB Clinical Working Group, option 1. So this will be fairly known to you who work here. RZE moxifloxacin 2 months, followed by rifampicin ethambutol moxifloxacin for another 2 months, and 5 months of rifampicin ethambutol. As I've said to you, the Americans, in fact, will go just for 6 months potentially. I expect they will extend it, but they will have moxifloxacin in extensive disease. Okay. So this is the bit where I'm just going to talk you through what we do at 2 months, hopefully that we then circumvent all those problems. So just remember, clinical review is still important. It's like a chest x-ray or CT scan. Check the sputum. Sensitivities, adherence, imaging. So talking briefly through it. At that point at 2 months, by then you hope you've had your TB nurses see your patient at least once or twice, correct? Okay. It should be expected. And then the next next thing you do is you actually weigh them, because some of those people are going to be putting weight on it, they'll cross that 50-kilo line, and again, you then have to rewrite your prescription, depending on your continuation phase. And obviously, if their weight is lower, ask yourself why. What's going on here? Are they sick from my TB meds? Are they not taking their medication? Have they seen the nurse? How many doses have they taken in total? Symptom response, important if you haven't got a mycobacterium in front of you. And obviously, you may want to examine some of these, because if it's a no, you no other way of really telling. Check the sputum. So again, this is, ask them to produce a sample, give them a pot. Do not actually ask them if they got a cough, because you will not get a sample. You say, you producing any sample, any sputum. What do patients tell you in 2 months? Good. Okay, let's say I don't have a cough, or I don't have any sputum. You just have to give them the pot. 2, is it a good guide to response and prognosis? Well, yes, and we can talk a little bit about that in a minute. If there is persistence, positive smear, it may be that there's a high burden to start with, or you have a problem on your hands, and that may be to do with absorption, adherence, or drug resistance. You don't have a mycobacteria with you. Certainly, the kind of WHO guidance is kind of different to what we do in the UK, because we don't see them at 3 months, do we? We see them at 2 months. Keep seeing them in clinics. If it's certainly persistent, WHO say repeat the sample at 3 months, then send it off for culture. I would say for our practice, at 2 months, if they are still positive on your smear, send it off and ask for drug sensitivity. Because there may have been a problem in the interim. You may want to consider PCR if it's really looking awful. And you can consider an extension of your induction phase. Don't forget, the definition of treatment failure, by the way, is the 5 to 6 month point. Okay, so at this point, you haven't failed yet. You need to be asking yourself the question, have I got this right? Is the patient taking medication? So why have I showed that slide? You're all too young. Great, film in the name of the character. On entry. You got kids. Sorry? He's very good. Jar Jar Binks, Phantom Menace. Why am I showing you this slide? You need to really get used to this kind of stuff, by the way. Do you remember the last moments just before this guy slumps over? What's happening? Someone's destroying the droid at the top. Okay? So lots of robots, all these battle droids around, they're all dead. And so that's the point of the 2 month sample. It may just be reflecting dead bugs. Yeah, I got that. Okay. So this is Dennis Mitchinson's guide to why you might not be winning. A positive sputum smear may mean any of these things. Some of them should make you wake up. So actually, the global estimates of smear positivity 2 months is about 10%. So you should expect about 10% of your patients still to have a smear positive. In some cases, we believe they may be related to a higher relapse rate. And this is the important thing. The negative predictive value is far more valuable than a positive predictive value because of the dead organism story. If you see it's negative, you sent off a proper sputum, you should feel quite happy with yourself and then feel quite comfortable in easing onto dual therapy. Bug. And this is a study of the extension phase. So again, some of us do this. I don't know what your practice is here locally. If someone's got a high bacillary load and their chest x-ray still looks awful, I will extend my induction phase. And there is some data supporting that, but the downside is I'm treating a lot of people who've got dead mycobacteria. Okay? As long as we accept that, we understand what we're doing, then I think it's okay to go in. Obviously, pyrazinamide itself shouldn't really have too much effect after 2 months just because of the mechanism of action. And you remember each drug is doing something different in TB. And isoniazid is up there with rifampicin, streptomycin. Pyrazinamide is working at the level of acidic milieu, and rifampicin for drugs that are having spurts of metabolism. So, if it's still persistent, ask yourself, are they taking it? 1, reassess, ensure optimized support. By that I mean, you may want to think about DOT if it's going wrong. Check dosing, you may want to check drug levels. And again, this would be not a common thing we do, but we do occasionally. repeat the sample at 3 months, reculture after drug sensitivities again, you can consider a PCR if you don't know what was happening before, and consider an extension of the induction phase. Sensitivities, again, another thing you want to check is actually, is it a real sensitivity you have in front of you? Check the hard copy or your EPR version. If not available, do not go to dual yet. So if something's growing in the lab, at that point, do not cut your regime down. You don't actually know what's around the corner, because in 2 weeks' time, they'll give you an isoniazid-resistant organism, and you'll be kicking yourself. If it's growing, don't go to dual. Is there an index if it doesn't grow? Find out what the index sensitivities are. If initially not culturing, then I think you have to make a risk assessment. Okay, and that depends on access to resampling, responses so far, seriousness of initial presentation. And again, if no cultures, you can go to dual if it's a kind of low risk and I think easy to resample. I, in some cases, will keep them with only famotol as well as rifampicin isoniazid if I don't know what's going on and I can't get back to that tissue. Obviously, take a risk factor. Fully reinvestigated resampling if doubt TB is the right kind of exercise. And I've got plenty of cases I'll show you recapitating young people with carcinomas. Literally a 32-year-old woman died with cavitate. Everyone assumed it was TB. There was a contact history, but actually all that time she had a bronchial carcinoma. Adherence, again, this is teaching how to suck eggs, but don't forget, tablet counts, again, generally not done by you because you don't have the patients. 2, you can just look at your urine sample, isoniazid sticks now exist. I'm afraid the butanol test doesn't exist, or if you have to supply, tell me because we can't get hold of it. And verifying those doses, adjust the dual plot. Okay, again, it's counting the dose numbers, not necessarily the days. Imaging, repeat the chest film, intrathoracic nodes. We will do just a plain film. We've got a bug in our hands that we can see shrinking down. CT when there is empiric treatment or if the diagnosis is unclear. And in extrapulmonary TB, obviously, think about other modalities. Again, I can show you a couple of horror stories where people have nodes from TB, cancers on the other side. And similarly, pelvic nodes with TB, cancer somewhere else, okay? So it's not going as straightforwardly on imaging as you'd like. Think again. Other tests, obviously, at this point, you want to check everything else, including their viral serology. And this is my picture of Graham Bottom. I think it's quite a close fit, don't you? Oh no, he's got more hair. Okay, so let's stop there. As I say, I hope it's kind of pragmatic walk through with this, but
So with the death rate in England for TB at the moment?
actually, deaths are relatively small, and our cure rates, by the way, the one thing the UK should be very proud of is our cure rates for MDR are as high as anyone else's. In fact, we're the top 2. Sweden and ourselves, we cure MDR better than anyone else. In fact, they've just come to visit us. All right. Yeah, that's
There's a very depressing program on TV the other day.
Yes, so fortunately we don't have that paradigm yet. Now, obviously, I think the more cases we have, the more drugs they've had before may make life more difficult. I think generally here we're trying to export them back. They get that difficult. I'll unbundle that for you. But yeah, definitely actually very, very, very low. And as I say, we're doing pretty well at the moment.
Lymph node TB, sometimes when patients are on treatment, they get the kind of virus and the nodes start to flare up again. You see that at the 2-month mark. You just clarify how easy is it to say this isn't a difficult TB case versus.
So that's what I'm saying. It's not going correctly. I mean, IRS, as you know, 25% of our patients are going to go up. Stick a needle back in and take a sample. And that's the simplest way of doing it. Don't do a PCR anymore. It's going to show TB again. It's not going to be helpful.
so far as e-busing them again?
Generally not, because obviously I think with those you have to have a rethink. We attempted on a couple of occasions, but generally not. Generally not going back in unless I really think there's any adherence or I don't have cultures, that's different though. We just need to go back in again, yeah. Great, thanks.